recap something which is not a small content. It's a full, huge specialty. And my job today is just to reconnect some of the facts. I'm well aware that you are good with these things and you have learned these concepts in the past. So I'll be only taking glimpse of the interesting features which are connected for the better understanding of this block. So with this, in this review, I'll try to go over certain things and my objectives. Let me Okay, so these are my objectives. Do you mind turning off the lights? Ali, thank you. Sarah did it already. So these are my objectives. You can read them through. I'll try to touch upon, I'm not saying cover, touch upon these concepts. And first of all, when we'll talk about in the urinary system, when we'll talk about the kidneys, the first organ where we should be engaged with, that is the kidney. And we should be able to locate what are the locations, how we can access a human kidney. So this image is really demonstrating you the location of a human kidney, and you can see from the back, the related structures has been mentioned and the lines and everything has been drawn here just to enable you to make you understand the location of the kidney. So you should be well aware of the things, and we approach the kidneys for various diagnostic and therapeutic procedures from the back and as well as laterally. Sometimes we have to go from the front, but those are extreme situations when we are dealing with cancers and other things. But these are details, and you'll be learning when you'll be rotating in the surgical wards, and there you'll be having urology orientation. There you'll be going in, you need to know more details about surgical exposure, but simply this one we'll using a very commonly done procedure, and that is the renal biopsy. That is done through a needle, which is being, if I know the location, then I can insert my needle very easily and I can have an access to the part of the kidney which I have to hunt, and then I can have a tissue diagnosis, and on the basis of that I can establish my diagnosis, and then we can start the treatment plan. So this important diagram where we should be aware of, and you can see this in diagram what you're looking at, how close relationship of my kidneys are with the ribs and the corresponding vertebrae. Going further, the beginning of the life, the kidney, when we talk about the development, we talk about pro, meso, and metanephrons. We all know about that. And kidney is the organ which originally is in the pelvic cavity, then it has to ascend up. And the testes or the gonads are the organs which are also in the posterior abdominal wall, but they descend down. So kidneys are going up and the testes are coming down. So these things should be clear. And you're looking at here pro, meso, and metanephrons, and this is the future of my urinary system. Going further, if I look at a human kidney, this is how it appears on a gross appearance. And it's a well capsulated structure. The capsule of the kidney has really very high significance. And it's really important when we are talking about management of the patient who are suffering from renal trauma. And also when we are talking about the malignancies, because the capsule and its significance are very relevant in those concepts. The kidney has different coverings. We talked earlier, and these are perinephric, paranephric, gerotal fascia, and the renal capsule. So these are the layers in which the kidney is being closed. None of them is a complete layer other than the capsule of the kidney. That's a complete wrap. Others are partial wraps. So they are not enclosing my kidney from all the dimensions. But the renal capsule is the one which encloses it from all the dimension. And you can see on the middle side, on the middle border, there is a structure, there's a pathway through which things can leave or enter the hilum of the kidney. And then you can see the artery vein are, one is going, one is coming out, and then the ureters. Ureter is what? It's the end product. Kidney, we all know, is the filtration unit of my body. And whatsoever we have in our blood, it passes through the kidney with very high pressure. There is ultrafiltration occurring, and the waste material has been separated from this blood, and that has been poured ultimately into the ureters. Those people who are suffering from chronic renal failure, we subject them to dialysis. It could be peritoneal dialysis or the other dialysis, and the job of that is just a kidney, which is an artificial kidney, and the job of it clean the blood of the patient. Those who are suffering from chronic renal failure, we need to connect them with these devices to separate out unwanted substances from the blood. And if we don't do that, those substances will be circulating throughout the body, and wheresoever this go, this toxic material will go, it will cause its problems, and the patient will present with a classic picture of CRF, chronic renal failure. And then other things which you'll be learning during this block. Now, we have cut this kidney at different levels to show you the internal structures. So primarily, I'm not going in the details. The most important structure, which are looking here, this outermost core, and that is called the cortex of the kidney. This cortical thickness is a real significant structure because the thickness determines the health of a kidney. If a kidney has a proper thickness of the renal cortex, means we are dealing with a healthy kidney. But as if there are different disease processes, I'm not going in those details. This cortex starts getting thinned out, and once it's completely thinned out like a membrane, so now kidney has, because the functional unit in human kidney is what? Is nephrons, and we have a huge number of nephrons, and they are embedded. They are the main unit where the filtration is occurring. When we lost the cortical thickness, when we lost the cortex, means we are losing the nephrons. We are losing the nephrons, we are losing the properties of what kidney is supposed to be in our body and what it is doing for us. And then ultimately, all what is being excreted from the kidney has been poured into the calyceal system. There's a detailed anatomy of the calyceal system, but not needed at the moment. So ultimately, what you have to remember, all the waste products from the kidney, which has to be excreted out of my body, reaches to this structure, this club-shaped structure, the renal pelvis, and primarily three major pelvises will be draining, upper, middle, and lower, and they are connecting to my renal pelvis, and the renal pelvis continues as the ureter. Ureter is a tube which takes away unwanted stuff, which has been ultrafiltrate, which has been taken out, separated out from the blood, and then it has to go out in the form of urine. You can imagine if you pass urine, if you collect urine in a container and leave it in a room, day after, you cannot enter in that room. So what this urine contain, my and your urine contain all the unwanted substances which are not needed by our body. So many medicines which we are consuming, they have been cleared out through the kidneys. So many goes through the liver and so many goes through the kidneys. So if someone is suffering from renal diseases, then we have to have limitations. We cannot give nephrotoxic drugs because kidney is already compromised. So we cannot give those drugs which are known for their nephrotoxicity. So you need to be considering when you are dealing with a patient who has failure situation in the kidney, you have limitation. You cannot subscribe everything to this person like a normal person. So you have to be cautious, and then you have to take certain measures. Going further, the kidney in its associated area, it's located, as I showed you in the first slide, in the posterior wall. And you can see how it is being closely packed. It's a retroperitoneal structure. It lives behind it, and you can see the close proximity of my kidney. And it is sitting on muscles. And one of the major muscle is the psoas major muscle. And the other muscles are also there. And then you can see the ureters, the pathway, they are traversing all the way down to reach to the pelvis, pelvic cavity, and ultimately they have to be connected with the urinary bladder. The entry of the ureters into the urinary bladder is not straight, it is oblique. And this obliquity, it's meaningful. If a person don't have this obliquity, what happens? when I have my bladder is full of urine and I'm delaying it for any reason. Now, if there is no obliquity, if there is no mechanism, so the urine starts ascending up and it may reach higher up. And then this is the reflux disease. Those who are suffering from these problems, we have stages of reflux. I have not inserted here. You'll be learning with your classes here. But so this obliquity, it prevents when the bladder is full, urine is not allowed to ascend up. When we are sleeping, when we are lying down, urine is not going up because the entrance point of the ureters into the urinary bladder is being narrowed and is being placed obliquely. So this acts as something like a sphincter, and that prevents the regurgitation. I'm using this different term here, but basically the urine is not allowed, reflux cannot happen, and urine is not going up unless this pattern has been destroyed for various reasons. Those people who are suffering from outflow obstruction. There are various reasons for having outflow obstruction. Could be one of them is a prostate, enlarged prostate. Could be other pathologies. And if someone is not taking care of that, so as a result of that, when the bladder stays continuously distended, full of bladder, so a time reaches when this obliquity pattern is lost and urine starts going up, and then it will lead to hydroureter, hydronephrosis, and then it's a disaster. It's a beginning of, and it ends as what? Chronic renal failure, and the end stage is the azotemia. And the whole job of relieving all these obstruction is to prevent what? Azotemia. If my patient reaches to this azotemia, this is a very bad news. So we have to intervene. We should not delay. People have a fear. Oh, I have a stone. I can look for this, this, and that. No. You have a stone, get a workup done, and get it removed. It's not necessary that you have to undergo a surgery. There are so many methods. If you see your doctor early, you can have a very easy, soft methods by which we can retrieve these calculi. Anyways, you'll be learning this with the time. So now you're looking at closely how the kidney posteriorly is related to some really important structure. As I told you, there are some muscles, there are ribs, and these are the nerves. Subcostal and ilioinguinal, these nerves are iliohypogastric, these nerves are there, and we have to be really cautious. When we are doing different procedures on the kidney, we have to be very careful and we should be clear about. We always have an understanding when we are subjecting our patient for renal biopsy, we take a consent of nephrectomy. We warn the patients that this is a very simple procedure. We are inserting a needle, but if it goes worse, it can go worst. We may land up in removing your kidney. With this consent, we perform this procedure, which is just a very small needle which has been inserted. But if you hit some major vessel, we all know the blood flows with a very high pressure. And if we cannot have control on the bleeding, definitely we don't leave somebody bleeding to death. So then we have to intervene and we have to do something meaningful. So we need to be very good for the relationship and remember, my kidneys, they move with each breath. When we are doing these procedures, we should ask the patient, hold your breath. And then we enter. Otherwise, we can have a vertical tear. So these are the important tips when these are useful when we are intervening, when we are doing a procedure which it's an office procedure. You don't need any, the hospitalization or any sort of anesthesia, just a simple needle inserted, going in, coming out. But if you're not cautious, you may land up with disaster. Now, you can see how closely it's associated some very vital organs. And you can see the duodenum, the second part, and the colon. While we are exploring kidney from the front, we need to be very cautious about these structures. And they are the real one who can do some issues with us. And now, the renal artery, you can see that it's a branch from my aorta on both the sides, and you can see when it goes, it branch and branch and branch till its final branches, and you can see the pattern, these arcuates and all those things. And these are really important because kidney is a filtration unit and the blood passes under high pressure, so it's a highly vascular organ. And we can determine on this investigation, which tells me the pattern of vascularity. This is the angiogram, and where we have inserted a contrast material, and now the whole vascular pattern is being visible to me. Otherwise, a simple X-ray will never demonstrate. Unless I have to insert a contrast, I use some other media, then only this whole pattern, how this vasculature is being located within the substance of human kidney. That has to be cleared out. Going further. So nephron, its different parts, their function, their relevance. So this whole thing is being given. I think physiology people will be talking in more detail. I'm leaving this part for them. They will go over with them, but you need to be good with that because you are in this block, renal block, and if you don't know about this, then probably you cannot connect every info which is related for your learning. Now, under microscope, you can see we take sections from different areas, and this is how my kidney appears under microscope. If I know the normal histology, then I can understand the disease processes, the pathology pictures, because if there's a disease, so there's a change in the normal pattern, and then we can figure it out what is happening, and we can determine things earlier. Now, normally the ureters are not visible with plain X-rays. Ultrasound is very difficult. We don't see the ureter. People do an ultrasound, and then they give a comment, there is a calculus. This calculus is visible, is not visible there. Because of this calculus, there is an obstruction in the flow. And then there is obstruction. So the ureter goes dilated. So then you can see this dilatation. And then, I have seen around everybody writes something, but please be very careful for these kind of reports. And people write, here I've seen imlah. Can you see imlah? No. People write this imlah. Just sand particles. So we have to be very careful. And this is one of the contrast study. Nowadays, it's not very common. There are other modalities, CT pyelograms and other things which are more safer. But this is an IVU. And what happens in this procedure, we inject a contrast into the vein and we take these X-rays with interval. And there's a time and we can take these. So this is called nephrogram when we are looking at that the pelvic calyceal system. And then you can see the ureter. The pathway is not showing continuous because there is peristalsis. So the contrast, you cannot see this part is silent, and in this part you can see it. You cannot see it. There you cannot see it, but there you can see. So this is because of the peristalsis. The contrast in a process of peristalsis, so peristaltic wave is visible with that. But this investigation helped me to learn the different parts of my urinary system, starting from the kidney going up to the urinary bladder. And if someone have a calculus obstructing anywhere, the contrast will not be going down further. And then we have to take a serial of X-ray. This is not one X-ray. This is probably 5 to 6 images, and then you have to look into each image, and then you can establish that what goes wrong. But this is just to show you the close relationship of ureters with the transverse processes of my vertebrae. Are we good? Going further. This is more in practice. CT scan, you can see very clearly, you can identify the location of the kidney, its posterior relations, and the associated areas. And this helps you to understand various growth, could be benign, could be malignant, to determine within the kidney, trauma, and various situations. This is a very helpful method. A CT scan is useful, and this is how my kidneys appear on the kidney on a CT scan. It depends on the level. If I'm taking at L1 and L2 and L3, so gradually we can see these similar things. Going further, these are further radiological methods because radiology is the key feature. If I have to understand the anatomy and the functioning of my structure and functioning, then we use all these modalities. And look, this is not a contrast. This is a stent, and we call it double J stent, pigtail stent, DJ stent, and we leave it in the pelvis of the kidney, and down you can see it's been coiled up because these two ends, they have a natural tendency When you insert it, it's straight. And when you take out the inside wire, then it coils up. So this coiling up function, it helps to retain this tube within the pelvis. Why and where we use it? If we are dealing with some kind of traumatic injury to the ureter, we have done some repair, so we leave this ureter, so the urine should not stay somewhere, so urine should be continuously passing. One, if someone has some stones, we are doing some SWL therapy, ESWL, extracorporeal shockwave therapy. So now what happens when we break these stones, the sand particles, they come and they deposit in the lower end. Now patient present with severe type of pain, and that's called Stenstrasse. So we insert this tube before subjecting our patient for this ESWL. So when the stone will be broken down into the sand particles, this sand should not obstruct the pathway of the urine, and patient has a free thing, and removal is very simple, very easy. You don't need even to anesthetize the patient. Just simple local anesthesia and you can just pull it out. It's an easy procedure. This is one way of approaching kidney. Another way is nephrostomy. We insert a tube which goes from the back and it also sits in the pelvis of the kidney. It depends on how you want to approach a human kidney. Are we clear? Because you'll be seeing a lot of people will be talking about DJ stent and all those things. So this is how it looks like. Now, these are different anomalies. Remember, when we are dealing with anomaly, when you encountered with an anomaly in any human being, never stay for one, never settle for one. If there is one, there must be more. So hunt for more. If you don't have curiosity, you will leave it, you will ignore it. And if my brain knows, I will see things. If my brain don't know, I will not see things. So you should have a visionary idea. And these are the different shapes. And in the beginning, when I was talking about the kidneys, they ascend. So in this situation, the ascent has been failed, and because the lower poles has been fused together. This is a classic of horseshoe kidney, pelvic kidney. I have put the various modalities, how the kidneys has been showing up in humans. These are the commoner ones. There are so many others, but this is the simplest one. Now, what are you looking at? We are dealing with someone who had ruptured his urethra, or we are suspecting a rupture in the urethra. How I can conclude that urethra is fine? So we inject this contrast that is going from the urethra, from the tip of the urethra, from the navicular fossa. We inject this contrast. Contrast goes up, fills up the bladder, and then we take images, and that determines the whole length of the urethra, and you can see the different parts of the urethra. Are we good? So guys, I have tried to go over simple, basic things, but sky is the limit. This is a full-fledged specialty. There are so many details, there are so many things, but I think this is just fine to start with. So with this note, I conclude here. Thank you very much. I'm open to your question if there is any. Any question? No question? Good. I like it. But still, I'm open. If you have any question, feel free to write me. I'll try to answer your stuff on an email. You all know my email. This presentation is being uploaded on your Moodle, and I think Sarah will be uploading the recording part, so there should not be any ambiguity. If you try to see in your Moodle right now, you will not able to open it up because I have put a restriction. I'll open it after 5-10 minutes, but it's there. Thank you very much. But I said it's on the Moodle. You don't have access to the Moodle? Then open your Moodle and take it from there. Why I should leave it on the You didn't listen. That part only.